I call this meeting to order. Welcome to meeting number 35 of the House of Commons Standing Committee on Health. Today we meet for 2 hours with witnesses on our study of the emergency situation facing Canadians in light of the COVID-19 pandemic. We do have some preliminary business that we should deal with right away as a result of the motion that was just passed in the House. We are now without our first vice chair, and it is customary to fill that vacancy. So I trust all of the campaigning is complete. The arms have been twisted, the deals have been made, and this will all proceed expeditiously. But I now hand it over to the clerk to preside over the election of the first vice chair.
I must inform members that the clerk of the committee can only receive motions for the election of the vice chair. The clerk cannot receive other types of motions, cannot entertain points of order, nor participate in debate. Pursuant to Standing Order 106, Bracket 2, the first vice chair must be a member of the official opposition. I am now prepared to receive motions for the first vice chair. Mrs. Goodrich?
I would like to nominate Dr. Stephen Ellis to be the first vice chair.
Isn't that a great choice? I think we all agree on that.
We know they're going to say no.
It has been moved by Mrs. Goodrich that Mr. Ellis be elected as the first vice chair of the committee. Are there any further motions? Is it the pleasure of the committee to adopt the motion? Yes. I declare the motion carried and Mr. Ellis duly elected as the first vice chair of the committee.
Congratulations, Dr. Ellis.
Comes with privileges and rights. Let's make sure the privileges are not rights.
On a very efficient and effective campaign. In keeping with our further discussion, I'll do my best to look after myself so that your vice chair's duties won't be too onerous. Today's meeting is taking place in a hybrid format pursuant to the House Order of June 23rd, 2022. All of the witnesses we have before us today are well familiar with the processes associated with hybrid meetings. Just one thing that I have to say, and that is that screenshots or taking photos of your screen are not permitted. The proceedings will be made available on the House of Commons website. In accordance with our routine motion, I'm informing the committee that all witnesses have completed the required connection tests in advance of the meeting. I will now welcome our witnesses who are with us this afternoon from the Public Health Agency of Canada, Dr. Teresa Tam, Chief Public Health Officer, Dr. Howard New, Deputy Chief Public Health Office, Stephen Bent, Vice President, COVID-19 Vaccine Rollout Task Force, Jennifer Lutfala, Vice President, Health Security and Regional Operations Branch, Cindy Evans, Vice President, Emergency Management Branch, and from the National Advisory Committee on Immunization, Matthew Tunis, Executive Secretary. Thank you all for taking the time to appear today. I understand that Dr. Tam will be giving the opening statement. Dr. Tam, you now have the floor. Welcome back.
Mr. Chair, thank you very much for once again inviting the Public Health Agency of Canada to provide an update on the COVID-19 situation in Canada. And I would like to acknowledge that I am speaking to you from Ottawa, the traditional unceded territory of the Algonquin Anishinaabe people. Comme je l'ai dit dans...
As per the public update that I gave on October 7th, virus transmission is occurring across the country with regional variation. The latest data up to October 8th shows that COVID-19 disease indicators, such as weekly case counts and lab test positivity, are stable compared to the previous week. At the same time, though, hospitalizations are elevated or actually increasing in some areas. This could be an early sign of fall resurgence. As gatherings and activities begin to move indoors because of the colder weather, COVID-19 and other respiratory infections will be able to spread more easily. While the risks of exposure may be increasing with more virus circulating, for many, immunity, thanks to vaccination and/or prior infection, may also be waning.
National Advisory Committee on Immunization, on NACI, recommends getting a COVID-19 booster dose 6 months after your last COVID-19 vaccine dose or your last infection. It is important that we all stay up to date with our vaccination to maintain our protection. In the coming weeks, seasonal influenza vaccines will be rolled out across Canada. It is good to know that influenza vaccines can be given at the same time as COVID-19 vaccines to people over 5 years of age. For many people across Canada, it has been 6 or more months since their last vaccine dose or infection. As a result, overall population immunity may be falling and leaving us all less protected. Only 18% of those eligible are up to date with their COVID-19 vaccinations in terms of having completed their primary series or received a booster dose within the past 6 months, with younger Canadians reporting lower coverage relative to older age adults. We now have 2 bivalent COVID-19 vaccine booster formulations that are good options for improving protection in people aged 12 years or older. And as of October the 9th, over 5% of eligible Canadians have received a bivalent vaccine. Both bivalent vaccine formulations target the original virus strain and the highly infectious Omicron variant. Likewise, both bivalent vaccines are expected to boost immunity against Omicron variants and broaden the repertoire of our immune response to the SARS-CoV-2 virus. Although there is temptation to believe that infection from the current circulating variant is not so bad, it is important to remember that infection also means continued transmission of the virus and carries with it the risk of developing post-COVID-19 condition or long COVID. There is scientific evidence suggesting that receiving at least 2 doses of a COVID-19 vaccine before infection reduces the risk of post-COVID-19 condition. The World Health Organization recently indicated that we have never been in a better position to end the pandemic, but while the end is in sight, we're not there yet. While transitioning towards a longer-term, more sustainable approach to the pandemic, we will continue to work in collaboration with our provincial and territorial partners, Indigenous communities, as well as key stakeholders. Pendant cette transition,
During this transition, we will continue to monitor for and prepare for worst-case scenarios, such as the emergence of more transmissible immune escape or more virulent variants. PHAC established pan-Canadian networks for a wastewater surveillance program, which enables efficient monitoring of a community for early detection and major trends in virus activity. Clinical and wastewater genomics continue to inform public health measures, predict and monitor the circulation of COVID-19 variants in community and institutional settings, and help us develop short-term modeling forecasts.
Continue to disseminate evidence and produce guidance to inform decision-making about response measures, with consideration given to the most recent evidence, the current epidemiological situation, and other key factors such as healthcare system capacity. The agency will continue to communicate on the evolving situation to Canadians, recognizing that uncertainties remain. In addition, the agency will support public confidence for vaccines and personal protective practices that empower Canadians to take individual and collective responsibility. The priority will continue to be protecting the health and safety of Canadians, and our path forwards will continue to be based on the best available science and evidence. Thank you. Merci. Miigwech.
Thank you very much, Dr. Tam. We're now going to proceed with rounds of questions, beginning with the newly minted Vice Chair of the Committee, Dr. Ellis, for 6 minutes, please.
Well, thank you, Mr. Chair, and thank you to the rest of the committee for their vociferous yet traditional confidence of electing me the vice chair. I really appreciate it, of course. And thank you very much to the members of PHAC and NACI and others who've come here today. Certainly, the anxiety level with respect to COVID and in the minds of Canadians has certainly subsided, but the ever-burgeoning threat, of course, of things moving indoors and the increased risk is there. Along that line of questioning, I'll go back, perhaps, Dr. Tam, to something we talked about multiple times before, and hopefully this time you'll be able to shed some light on this for all Canadians. If we are talking about increasing measures with respect to perhaps access and mask wearing, et cetera, I believe the Canadians want to know which metrics or benchmarks the Public Health Agency of Canada will be using to make those decisions. And I realize that previously you have told this committee multiple times that it's much too complicated for us to understand. I take that with great umbrage, of course, but would appreciate your comments with respect to that today.
Mr. Chair, thank you for the Vice Chair for the question. Of course, many of these measures are taken at the local and provincial levels as well, not just by the federal government, as the current status of public health measures are really decided more at that local level. So I think there is a combination of different assessments and metrics. So first of all, we have to assess the virus, the variants that are currently circulating and their characteristics. That includes how transmissible they might be, whether they escape immunity that have been developed through prior vaccinations or prior infections, and their virulence, how severe are those virus variants. And of course, ongoing study of the host and the population level immunity, such as through serosurveys of the that has been undertaken by the Canadian Immunity Task Force. The capacity of the healthcare system is very important, and as people have seen, when the hospitals, emergency rooms, and other places are stressed, that needs to be taken into account in terms of whether, for example, mask wearing would help at least reduce some of that spread and the impact on the health system. And if any public health measures are put into place, it is there to buy time as well, and so really during any kind of that time period, provinces and all levels of government have to take action, including adjusting any of the recommendations and guidance required. So it's also a balance between reducing transmission and impacts, and of course, the potential negative effects of some of these measures on society.
Mr. Chair, and thank you, Dr. Tam. I appreciate that answer. Certainly different from before, and I really hope this can improve our working relationship as we go forward. I don't think it's related to my new title, but maybe it is. Maybe you could speak in the next minute and a half or so, Dr. Tam, through you, Chair, with respect to variants of concern on behalf of all Canadians.
Yes, so I think it is really great that during the pandemic, more capacity has been provided for us to monitor genomics and other characteristics of variants concerned. So the Public Health Agency and indeed our National Microbiology Laboratory and our provincial territorial lab works have, and globally, have been monitoring the ongoing evolution of the SARS-CoV-2 virus. The trajectory of viral evolution has changed over time. This is quite interesting. The earlier variants have multiple and often very divergent evolutionary pathways, seeing as there were no vaccines, therapeutics, broad-based population immunity to constrain the range of the mutations. More recently, however, multiple lineages descending from the Omicron variants, that very transmissible variants, have begun to develop multiple identical mutations, and a phenomenon that we're calling evolutionary convergence, and we have to learn more about that. So you may have seen or heard a variety of these variants, such as BA 2.75 and 0.2, BA 1.1, BA 4.6, and a multitude of BA 5 descendants, have these convergent evolutionary mutations. So the very important thing about monitoring is these mutations is that there seems to be when there's broad population immunity, it puts pressure on the virus to find advantages, such as escaping our existing immunity from infection or from vaccines. So this broad range of the descendants of Omicron are now being carefully monitored.
And other than that, certainly there are potentially other variants coming down the pipeline, of course, and communicating with other countries is essential. Are there any other specific, I'll use the word scary variants of concern out there, Dr. Tam, at the current time?
At the current time, they are all descendants of Omicron variants and subvariants, and we haven't detected any very extraordinary appearances as yet. But that is a scenario that we're planning ahead for. For example, if there's a very distinct immune escape where vaccines don't work or treatments don't work and they cause severe illness, that's one of the worst case scenarios. We haven't detected one of those yet, but we need to be prepared for potential.
Thank you, Dr. Tam. Next, Dr. Pawlowski, please, for 6 minutes.
Thank you, and I'd like to welcome Dr. Ellis as the new Vice Chair of the Health Committee. I think things are looking really good with respect to COVID. Usually when school returns, that's the time for a real rapid spread of disease, and we really haven't seen that. So I find that really encouraging. Now, prior to this meeting, I kind of looked up like what is of concern right now, and I understand there was a Swedish study recently looking at the BA 2.75.2 variant, which there's some concern about, even though the variants which are common in Canada right now are the BA5 and the BA4, the BA 2.75.2, which is apparently a lot worse than the one without the 2 on the end, apparently studies show that it seems to escape what is no longer sensitive to the antibodies that are out there, either as a result of the vaccine or previous infection. Now, I'm not sure what that means. Apparently, in India, this has been around at least for a month. It's present in 40 different other countries. I saw news reports of it in India a month ago, and yet there doesn't seem to be any reports of large numbers of people being hospitalized or deaths in India. Can you tell me what you know about that variant? Because there does seem to be concern about the effectiveness of the vaccine against that variant and the treatments.
Mr. Chair, thank you to the member for that question. BA 2.75, and indeed it's actually BA 2.7.2, is the specific sublineage that we're monitoring, and is part of the group that I mentioned in the response to the last question. So this BA 2.75 and its sublineages currently represent 1.1% of the sequences detected in mid-September, and has stalled recently in Canada. However, it still needs to be monitored because BA 2.75.2 is consistently growing faster than other of the BA 2.75 sublineages that we're monitoring. But the vast majority of sequences in Canada at this point is still BA5. But BA5 has many different variations that we're monitoring, as I've said in my last report. So the member is correct in that one of the concerns is it's able to evade potential prior immunity or monoclonal antibody treatment. But the good news is that we do have these bivalent vaccines now on board, and all of the vaccines so far actually has had good impact on severe outcomes. As well, we have treatments like Paxlovid that is not a monoclonal antibody, and that is available for those at the highest risk.
Now, from your response, the BA 2.75.2 is 1% of the the cases in Canada and hasn't been increasing? Do I have that right?
Yes, its growth has been observed, but it's stalled, it's slowing. On the contrary, BQ 1.1, I think some of news media has been covering that, sublineage, which is a descendant of BA5, has a faster growth estimate at this point, and it only represents 0.6% of our current sequencing that was last reported. But because of the rapid increase and acceleration, for example, in European countries, that one deserves close attention.
Now, a number of people, including my daughter, asked me this yesterday. She said, "Dad, should I get the bivalent vaccine?" So can you make a case for the bivalent vaccine versus the previous vaccine?
Yes, so the National Advisory Committee on Immunization, and Dr. Matthew Tunis is here with us, and they made a recommendation to preferentially use the bivalent vaccines, both Moderna and Pfizer, now that we have them, because it contains both the original virus strain as well as the Omicron variant strain. And that helps to not only boost your antibody level when you get the booster, and if you haven't had it in the last 6 months, go get one. But it also broadens the repertoire of your immune response. So it does more than just boost levels of antibodies. The way that these bivalent vaccines are constructed, we believe it will increase the repertoire of the immune response itself.
Now, one of the frequently heard criticisms we've heard about the messenger RNA vaccines initially was we don't have much experience with them. They're new. Now, that argument's getting a little tired in that it's been over 2 years since we've been using those vaccines, and seemingly we haven't seen any great rise in adverse effects as a result of the vaccines. Now, I think a lot of people, especially with their kids, and I've got a bunch of kids, when you're talking about the new vaccine, the new combination vaccine, again, okay, this is a new vaccine again. So what can you say to reassure us that this combination vaccine is as safe as the original vaccine?
Yes, so Health Canada, of course, has a well-established process in evaluation, both the safety, the immunogenicity of the vaccines. And of course, after any vaccine is launched, we will have post-implementation studies, especially on safety, but also on effectiveness. And as you've indicated, millions and millions of doses of these vaccines have been utilized globally. And just because we are adjusting one of the strains doesn't mean that any of the other processes would change. The manufacturing process and the way that the vaccine is made. So all of those have been assessed as usual. And I think one of the best analogies I would make is it's a bit like changing influenza strains and updating them every year. The similar kind of concept is being used by the regulator. We know a lot about these mRNA vaccine now and their safety. We're just swapping out and updating the strain itself.
Thank you, Dr. Tam. Suite, Monsieur Garand pour 6 minutes.
Mr. Garand, you have 6 minutes, sir. Thank you very much. Thank you to all the public health officials for being with us here today. I would like to pick up on the questions put by my colleague. It's always a bit daunting to have doctors on a committee. I'll try to put questions as intelligent as theirs. Now, we felt that people who had already had 2, 3 boosters are somewhat tired of all these boosters. Now we feel that with this new bivalent vaccine, the public is once again interested in vaccination. Once again, the media are picking up on vaccination on a positive note. Do you think that we can take advantage of this to pick up on vaccinations that had been slacking off? Thank you for your question.
Mr. Chair, this is an incredibly timely question because, yes, I think our public research, public surveys have demonstrated that people are interested in an updated vaccine. I think people do understand that respiratory virus season is upon us, and people are going to get further and further into gathering indoors and being able to go to school and go to work on sites. So all of this means that there does appear to be a rising interest, which is really great. And so we do have a 7-point action plan to help Canadians improve uptake. And so a lot of that, of course, is working with the provinces and territories and the local health unit. You've seen their campaigns rolling out now. You're going to see more and more messaging coming up in the next days and weeks, and the momentum is gathering. And from the Public Health Agency perspective, we've launched ad campaigns. One's called Lots of Questions that launched at the end of August, and a Take Action ad campaign. We're also, one of our key strategies is to support communities that may have a lower vaccination coverage, equity deserving communities, multilingual formats, and targeted mail outs to populations where vaccine uptake is lower and there has been high community spread. Of course, social media campaigns, shareables, partnering with stakeholders, including private sectors, as well as, of course, press conferences. But it really does take the engines of local public health as well to get the campaign rolling. But it's also going to be the start of the influenza campaigns. So this is why we're encouraging people to get both if they're eligible.
Merci. Écoutez,
Thank you very much. Look, despite the fact that I'm very optimistic, and I certainly intend to go get this new bivalent booster next week, we seem to be facing a situation where this new bivalent vaccine will lose the information war. For example, in Canada, when it started being distributed, and I have the Consultative National Advisory Committee's advisory here, people are being asked to go and get this bivalent vaccine. And then we have France Presse picking up on the OMS's information to the effect that we haven't enough data to be able to recommend any vaccinations specifically targeting the Omicron variant. So it seems out there that Health Canada is saying, get this bivalent vaccination, this booster, and now the World Health Organization is saying, no, we haven't quite got enough data to be able to fully recommend it, and so on and so forth. So what are Canadians to make of all this?
It is very important that we communicate clearly with Canadians, and the National Advisory Committee on Immunization has been very clear in that if we haven't had a booster within the last 6 months or haven't been infected in the last 6 months, please go and get your vaccine up to date. And this is after Health Canada, of course, has done its evaluation on safety, on the immunogenicity data that the manufacturers are able to provide, and some of the clinical data, for example, from the Moderna vaccine manufacturers. So all of this has been taken into account to provide the information for the recommendations. Given that Dr. Tunis is actually on the panel, and I'm wondering if I could pass the mic over to him to just provide a little bit more detail on the...
Well, it's just, I could put the question again just to make sure that it's clear. When the World Health Organization states we haven't enough data to be able to recommend it, well, you know, people read that, hear that as a counterindication. People who aren't specialists, you see. So I'd like you to explain exactly what the World Health Organization has in mind when it publishes this sort of statement.
Yeah, so thank you, Dr. Tam, and thank you, Chair, for the question and the opportunity to respond. So it's an excellent question, and part of the challenge here that we see is we have an expert advisory committee like NACI who provides expert and evidence-based advice to provinces and territories and to the Public Health Agency of Canada, who then turns that into communication materials. And what we see is a very motivated and interested media and public who likes to look directly straight to the source to see from an advisory committee what is the advice. So there's some complexity, I think, in the communication pathways there. But something that we've seen throughout the pandemic and throughout the vaccine program is that NACI has consistently given advice in real time as evidence continues to evolve. And so what the member may be referring to is when the bivalent vaccines were first introduced into the booster program. As Dr. Tam mentioned, NACI recommended that bivalent vaccine could be used as a booster option, and that boosters were important, particularly for the elderly and with the 6-month interval, as Dr. Tam outlined. And as the product environment has evolved and as the evidence has strengthened about the bivalent boosters, NACI has recently recommended now that bivalent vaccines are in fact preferred for those in the authorized age groups where they're available, which again demonstrates an evolution of the science. So the expert advice moves along as the science strengthens and evolves, then the committee adjusts the strength of their recommendations, and they would say, well, now it's clear and there are two good options for this bivalent product, and the committee was of the opinion that this would be preferred now. So that is a strong recommendation for the bivalent product as preferred, whereas earlier in the program, it was being onboarded as one of the many important booster options. So I think that this is something we'll continue to see occur as expert advice is evolving in real time, when we know the COVID-19 evidence and vaccine science is evolving as quickly as possible. And we're all very closely reading every preprint and every publication that comes out to try and get the edge on the virus and get the edge on the best science. So that's, I think, is a function of the system of this medical and evidence-based advice coming through in real time as things are evolving. But as Dr. Tam mentioned, the important takeaway is at this point, the bivalent vaccines, those boosters that are approved for several age groups, have been shown to have high levels of antibody, which we expect will result in protection against Omicron and the other variants. And the goal this fall of the program is to use those vaccines to try and diversify the immune response, not necessarily to have the closest match to exactly what is circulating today, but we know that Omicron variants are the most distinct from the original ancestral strain. So providing a vaccine that covers both of those allows the immune system opportunity to establish a strong breadth of protection that we think will be important going through this winter for the program.
Thank you, Dr. Tunis. Mr. Blakey, welcome to the committee. You have the floor for the next 6 minutes.
Well, thank you very much, and thank you to Mr. Tunis for those comments. If I understood Mr. Garon's question, I think it revolved around, and I think it's an important question because it speaks to the confidence that Canadians have. We know that it's been a difficult time in some cases in respect of trust. And so I think what we are concerned to do around this table is to try and help build confidence in those recommendations. And I took him to be asking, I guess, essentially whether Health Canada has access to evidence and data that the World Health Organization is not using, or whether Health Canada has the same data but different criteria for what would count as sufficient to be able to make a recommendation, because we do have a curious situation where the WHO is saying there's not enough data to make a recommendation. We have our own National Advisory Council that's done very good work through the pandemic saying that they're satisfied they do have enough evidence to make a recommendation. So can you please help us to understand the difference, whether that's a difference in the data at your disposal or whether it's a difference in the criteria you're using to assess the adequacy of the evidence, as to why we have apparently competing proclamations?
Mr. Chair, thank you for that question and further clarification. And just to emphasize that we have to look at what point in time these different organizations are communicating. Right now, it's not just Canada, the United States, the European regulatory agencies, and indeed countries very similar to our own, who have access, of course, to the manufacturer's data and their own epidemiologic information, have all recommended the bivalent vaccines. So that may be something that we need to consider. And I really want to thank the committee for trying to bring this point out so that Canadians can understand. And Health Canada, who is not here today, our regulator has very strong safety and effectiveness criteria that they put to bear. And they do talk to the FDA and the European Medicine Agency. and the United Kingdom, for example, and they exchange information very closely, and so that they do share the data and they have similar data in front of them.
And
Thank you.
If I can,
Yes,
I
Mr.
could
Tunis,
add
please.
as well, Mr. Chair. Yeah, if possible, thank you. We work closely with our international counterparts, and we know that many countries, and including the WHO, has an advisory committee of experts similar to in Canada. And so we do often see these advisory committees having common threads of understanding, as Dr. Tam mentioned, but we also see areas of deviation. And what's important to understand and to remember is that every country has a unique context and unique environment. In the case of the WHO, they're in fact speaking to the entire global context. In Canada, NACI is taking the Canadian information and evidence, the Canadian supply context into consideration and the available products. So while the WHO have certainly not recommended against bivalent products, they're recommending that those can be included as part of the booster suite, but they're not making a distinction or a preference among the different products. Whereas in Canada, based on the supply context, the availability of the products, and NACI's expert assessment, their recommendation was, in fact, that the bivalent products could be preferred. But I think an important sort of level-setting piece of information is that all of these countries are recommending booster programs. It's a question now among the suite of available products, which one might give the best edge, and there will be different expert assessments as the evidence continues to evolve on that. But at the end of the day, WHO, NACI, other countries are recommending that boosters should be used as part of a fall framework, as part of a preparedness against the winter season, the strains to come. And we are seeing the bivalents be recommended and used quite broadly in Canada and in Germany, in the US. There's been a preferential direction towards bivalent, but I think that there is actually not a large gap between the position of NACI and the WHO on this. Thank you.
Yeah, well, thank you very much for that answer. I think that was quite helpful. And what I'm hearing is that Canadian organizations are paying attention to what other international bodies are doing, but also have, if not privileged, then at least specific information relevant to the Canadian context. And when Canadians are asking themselves which body they should go to first for the best advice for themselves and for their families, it's the organizations based here in Canada that have experts that are paying attention to all of the many types of statements that are being made on the international stage, and then adding that Canadian-specific information to issue in particular recommendations for Canadians. And so I thank you very much for making that case clearly. Of course, public trust factors into that, and we want people to have the maximum amount of trust in our Canadian institutions as they can. One of the things coming out of the SARS experience was an emphasis on the need for an independent evaluation on how the Canadian government and Canadian officials performed in that context. That's something that hasn't happened yet here in Canada in respect of the COVID experience. I'm wondering if you can speak to the importance of having a public inquiry, independent advice, not necessarily because the findings are going to be different than Health Canada's own internal processes, but because I think it helps Canadians enjoy more confidence in those findings when they know that it's coming from an independent source. So if you could speak to the value of that independent investigation and perhaps give some thought or express some views about the timing of such an investigation, I think that would be welcome. Thank you.
Okay, to the witnesses, Mr. Blakey has well exceeded his time, but would be interested in a brief response if that's possible. Thank you.
Thank you, Mr. Chair. I can't comment on the specifics of any such reviews and inquiries, but all I have to say is that we've just been through the biggest pandemic of the current era, and it is very important to take note of lessons learned and be as objective as we can. So, inputs from a variety of experts on what went well as what could be improved is important to set us up well for our response going into the future, given that pandemics will occur again.
Thank you, Dr. Tam. Ms. Goodridge, please, for 5 minutes.
Thank you, Mr. Chair, and thank you to all the witnesses for attending today virtually. It would be lovely to be able to see your smiling faces here in person, as I do believe it does often add to the richness of the back and forth dialogue to be able to have our witnesses here in person, but alas, I won't harp on that. One of the interesting things, and I'm not sure if you guys follow what goes on at the Health Committee, but I've brought up on numerous occasions, as have some of my other colleagues, concerns around the lack of pediatric formulations of over-the-counter drugs, specifically infant, Tylenol, Motrin, and Advil. And this is especially concerning as we're approaching cold and flu season, where parents are going to need more of this. What would you recommend to parents on how to go forward as we approach cold and flu season and in this COVID era where there is no over-the-counter pain medication available?
Mr. Chair, the supply of these medications isn't really in the purview of the Public Health Agency. But I would say that, of course, prevention is key, and that getting up to date with vaccination is one way of preventing certain respiratory infections. And certainly there are other ways, for example, to soothe children and reduce fevers, and that kind of information should be made very readily available, including through pediatricians and the Canadian Pediatric Society. And I think there's work done by Health Canada and others in the federal departments to link up with pharmacists and pediatricians and others to address the situation and also provide parents with sound advice.
Thank you. I don't think that's necessarily going to provide a lot of comfort to parents to tell them that there are other ways they could deal with their child's fever. They're probably going to end up taking them to the emergency room at 2 a.m. Rather than provide them with the pediatric pain medication that would just solve the problem. And I think this is one of the big issues that where I see a major disconnect between what the advice we get from the Public Health Agency of Canada and what we hear on the ground. I represent a large rural riding in northern Alberta. They see your press conferences and they don't feel heard. They don't feel like you have been on the ground in many rural and remote communities to actually understand some of the day-to-day experiences. And so I would encourage you, and I guess I would ask, have you gone outside of Ottawa to hear from people directly and see what things are looking like on the ground in Canada?
Well, that's an important point, and for sure we have different roles and responsibilities between the federal, provincial, territorial, and local governments, but it is important to hear from communities, so that's a really good suggestion. But all I'm saying is that, I know that my colleagues in Health Canada, and indeed the Minister has been working very diligently to look at the supply situation for the medications that you just talked about. It's just that it's not the day-to-day responsibility of the Public Health Agency, and I want you to get the best information from the right department, and we can certainly reach back to our Health Canada colleagues on that front.
Thank you. And so from that answer, I can ascertain that PHAC, yourself, have not traveled to see what the state of the COVID response is outside of Ontario.
I think of course, I always work with the other chief medical officers, and it is their responsibility as well for their own communities. But we also have regional offices of the Public Health Agency that are placed across Canada and they have been our eyes and ears to on the ground to the local situation, and indeed to link with local jurisdictions in terms of public health. And we work very closely, of course, with Indigenous Services Canada, because one of the key federal populations that we have to listen very carefully to is the Indigenous peoples.
Not to interrupt, but just a yes or no question. Have you traveled outside of Ontario to see what the COVID situation is on the ground?
I have been fortunate to be able to go to Quebec, to Montreal, but also to Vancouver. No, I have not traveled extensively, but as I said, we have many staff who are on the ground.
Thank you, Ms. Goodridge. Next, Mr. Vancouverden, please, for 5 minutes.
Thank you very much, Mr. Chair, and thank you to our witnesses today for your appearance today, but for your extraordinary work over the last couple of years, which has been one of the most important times and difficult times for Canadians, but certainly for the healthcare sector as well. I would also just like to point out that I think most Canadians recognize, Dr. Tam, what your role is as the Chief Medical Officer of Health of the Public Health Agency of Canada, that you're not a politician, and that traveling around from community to community to liaise with Canadians isn't part of your mandate. I would also just like to say that in general, Canada is in a good place today, and it's in large part due to the fact that we've had reasonable restrictions and a very high vaccination rate. There are still, tragically, 45,000 deaths as a result of COVID-19 in Canada, but if we had similar numbers to the United States, that number would be triple. And that's a daunting thing, that an additional 90,000 Canadians wouldn't be with us today if we had different restrictions. That goes for France and Sweden and Spain, which would also indicate that those numbers would be double. So by all accounts, I think Canadians have a lot of confidence in our public health care system, public health in general, and I want to thank you on behalf of all Canadians for the extraordinary work that you've done. Sorry, I'm just having a little bit of trouble hearing myself. There's a lot of chatter going on in the room. I think it's important that we all recognize that we have time to speak and time to listen in this room. But Dr. Tam, to you, through the chair, we have seen recently in the media that Canadians are starting to become a little bit tired of keeping up with vaccination. There's the sense that a lot of Canadians have that the fact that the COVID-19 is over, or that they don't need to worry about COVID-19 anymore. And we're fortunate to be in that situation due in large part to the number of Canadians who have gotten out and got a vaccine. But it's important as spokespeople for our communities and as well elected officials that we provide Canadians confidence and information with respect to vaccines. So could you share with this committee how we can all work with your agency and among ourselves to increase confidence within Canadians and give them all the information they need in order to go out and get vaccinated, continue this positive trend that we're all fortunate enough to be experiencing?
Mr. Chair, I want to thank the member for that question, and I have a colleague, Mr. Stephen Bent, Vice President of the Vaccine Rollout Task Force, who can supplement my answer. And I've, in my previous response, described some of our 7-point immunization action plan, which aims to boost the confidence of Canadians for the bivalent vaccines. And that includes communicating with Canadians in multiple different ways and formats that I've outlined. It is really, we know that through numerous surveys that Canadians trust their healthcare providers, so providing information to our pediatricians and to our physicians and nurses and pharmacists who are on the front lines, and so that they can answer questions from the public is very important. Clearly communicating what now is a very quite a clear message from the National Advisory Committee on Immunization to get a booster if you hadn't had one, or if you hadn't had an infection in the last 6 months, is actually a very clear message that all of you and others could communicate as well. And then building trust, of course, with communities that have been disadvantaged and experiencing equity over the years, inequities, and working with them so that their leadership can provide a voice to their populations to take action to get a booster. And there are funding that we're providing through grants and contributions to specific communities to help them improve their vaccination rates. So maybe Mr. Bent would like to add something to my response.
Thank you, Dr. Tam.
Mr. Chair, point of order.
Yes, Dr.
I'm having a hard time listening to the response. There's a lot of chatter in the room. I wonder if you could address that. Thank you.
Okay.
Mr. Chair, just also to weigh in on that. I know there's a few new members around the table. For someone who's been here, I guess, for 7 years, we have these handy little headsets that they can absolutely put in if they'd like to offer. That's free advice, I guess, for the new members to listen to if they're having so much difficulty hearing.
Okay.
Thank you. And it's still my time, Mr. Chair, and I would like to say that we all have and know about these. That was fairly condescending to tell us that we have a way to listen when if the witnesses were in the room, talking over them would be seen as an extraordinarily disrespectful thing to do. It's fine to talk in a group if you'd like to avail yourself of any of the other spaces in this room. If the witness was in the room, you would not be talking over the witnesses like that, and it's extraordinarily rude. And I noted that you were doing it while I was asking my question as well, and it's extremely distracting. We're here to work, and we're here to listen to these witnesses. If you're not interested in listening to the witnesses, then use another part of the room.
Okay. If we could show respect for one another and for the witnesses, that would be greatly appreciated. Mr. Bent was about to offer an intervention, and if you could keep it brief, Mr. Bent, then we're going to retreat to our corners and move along. Thank you.
Pardon me. Thank you, Mr. Chair. No, I would only add that this year alone, we've been able to invest an additional $5.3 million in projects to reach under-reached and marginalized communities, including Indigenous and racialized communities. And then I would also add, in the context of vaccine confidence, we continue our work with our provinces and territories and with the regulator in terms of vaccine safety. So ensuring that Canadians have the latest and most up-to-date information in terms of the overall safety of and efficacy of the vaccines that we have available to us. And that's a really important part of this space as well. Thank you.
Thank you. Monsieur Garon pour 2 minutes et demie.
2.5 minutes, Mr. Garon. Thank you. Dr. Tam, I nevertheless seem to feel that the best asset for a public health officer and their association is public confidence, is trust, because advice is given to the public, and we hope the public will believe us and follow the advice. We're at the end of a pandemic, or, well, towards the end, and we're carrying out a sort of post-mortem. During the pandemic, many Canadians had trouble telling the difference between political statements and scientific statements. We had difficulty telling what you were actually advising the government to do, what analyses you were sending to the government, and what was political. And very good. You know, of course, we need politicians to make decisions to ensure that society works in lockstep and people move forward in difficult times. I'm not here to question that. But here's my question. What might have been done differently to ensure that the public trust the scientific process, which led to the mandates, the vaccination, the health directives, and so on? What might have been done differently? And Dr. Tam, I don't want you to run through my 1.5 minutes telling me what you have done. I would like you to tell me what you might have done differently, what might have been done differently. And communication, of course, is part of the scientific process when it comes to public health. So let's not do politics. Let's tell me what could have been done differently.
Thank you for the question. And yes, trust is really important. And I am not a politician, as you've rightly pointed out. But because we're dealing with extremely complex decisions, it is ultimately the political decision makers that make those decisions. We provide technical information, both to them and, of course, communication with the Canadian public. There's a lot to be learned, I think, about how we communicate uncertainty when we don't have every piece of data that we have, and to, of course, be able to navigate and bring the population along as things evolve. And that happened throughout the pandemic because the virus was new and we had to learn practically every day about how it's changing and what measures can be done to reduce its impact. So that is very critical to future pandemic preparedness.
Merci, Monsieur Caron.
Thank you, Mr. Caron.
Blakey, please, for 2.5 minutes.
Thank you very much. I think for most people, when they think about their experience of the pandemic, there's the personal side in cases where they may have had a friend or family member themselves who got very ill, and all the anxiety and worry that comes with that. And we've talked a fair bit about vaccination already, which is, of course, the best way to try and prevent similar instances in the future. The other thing that I think is part and parcel of people's experience of the pandemic, even if they didn't get sick with COVID themselves, was just the extreme strain that it put on hospitals. And they may have experienced that in the case of a loved one. They may have experienced it in their own case, requiring health services for something that was unrelated to COVID, but where the treatment and availability of health resources was severely impacted as a result of the level of infection and just how difficult it was for the health system. So I'm wondering, in this moment of, relatively speaking, apparent calm, what we can be doing in order to try and strengthen health systems and to shore up our hospitals in the event that we do see another wave or something else that comes along that requires a significant amount of health resources. Now, I know provinces, of course, are responsible for that direct delivery, but in health human resources, for instance, we're going to need to train more people. Having 10 different provincial strategies that are competing and might incorporate poaching, for instance, as part of their strategy will not be helpful. Some kind of national collaboration and cooperation might help there. I wonder if you could point to other areas where cooperation among provinces and with the federal government might help us develop a faster response or to be ready more quickly for events that may be coming down the line.
Mr. Chair, thank you for that question. And given the nature of a pandemic and complex public health challenges, it has to be a huge amount of collaboration between provinces and territories and the federal government. No level of government can do this alone. In terms of the healthcare system pressures, on the public health side, what we're trying to do is promote prevention and health promotion so that we reduce the impact on the health system. It's very important to have emergency rooms, primary health care, and other systems being more resilient. But part of the solution is actually shoring up public health. So you've seen in the pandemic, if vaccinations and other measures were not put in place, those very systems will be even more pressured than they are before. And we need to protect our healthcare workers. So I think those kind of collaborations are absolutely key. And of course, we need to collaborate on monitoring, sharing of information and data to inform our collective response, while recognizing that there are different contexts, different populations, and indeed different virus activities on the ground.
Thank you, Dr. Tam. Next, Mr. Genereux, welcome to the committee. You have the floor for the next 5 minutes.
Thank you, Mr. Chair. And despite my earlier intervention, it is a real pleasure to be here with every single one of the committee members, but also to be back at Health Committee. Dr. Tam, it's good to see you once again. Dr. New, it's been a while since our very many meetings back in early 2020 in the lead up to the pandemic. But that's kind of where I would like to start, if we can. There are a number of here quotes that I know have been associated with you, Dr. Tam, that I'm going to read, and then would like you to perhaps reflect upon what we could do differently or next steps that could have perhaps been taken earlier to prevent the rapid spread of at the beginning of the pandemic. So first of all, Canadians should not be concerned that they can pick up the virus from an infected individual by any casual contact, such as walking through the airport or any other public space. Dr. Tam, that was you on January 27th, 2020. Sealing off the borders is not an effective approach to containing the virus. That was you, Dr. Tam, on March 4th, 2020. Putting a mask on an asymptomatic person is not beneficial. Dr. Tam, that was you on March 30th of 2020. And Dr. New, I certainly won't miss a quote from you as well. On February 26th of 2020, you had stated, "We have contained the virus." So again, reflecting on what perhaps you could do differently at the beginning of the pandemic and steps to stop the rapid spread, would love to hear your insight based on those quotes.
Mr. Chair, I'll start, and thank you, the member, for those questions. And that was partly my reflection on lessons learned, is that, hindsight is 2020. Information and the evolution of the understanding of the virus was changing all the time. At that point in time, at the end of January, we were very good in Canada to be able to pick up our first case, but there was no discernible community transmission at that moment in time. But things, as everyone could see, was evolving fairly rapidly. And so I would suggest that for pandemic preparedness going forwards, we need increased global collaboration, sharing information, and more rapidly, if possible, reduce the rapidity of transmission from the original source if you actually knew where it started. But something that is transmitted the way that this coronavirus was transmitted change over time. At the beginning, the R value, what we call the reproduction number, wasn't that high. And then it just kept gaining more and more momentum. And our understanding of asymptomatic transmission came into play. That's when we really stepped up the recommendations for mask wearing, when it was much better understood. But we need to have humility in the face of these viruses for sure. And I'm sure there's a lot we can do, but shoring up public health is a really important aspect of preparedness going forward.
Mr. Chair, it's Dr. New here. Maybe I could add in terms of, I guess, the comment attributed to me. If I recall correctly, the date, those comments were actually made at the Health Committee here. And then certainly if you look at the larger context, what I indicated at that time is that certainly I think it was a member general reported, I guess, February 26th, the Health Committee. I did indicate at that point in time, certainly with our efforts to date, that the virus had not sort of obviously transmitted to a large degree. But certainly if you look at all of the comments I made, I said that we continue to work closely with the provinces and territories in terms of planning for sort of a potential worst scenario. And one of the things I did mention, I do recall at that committee, was that things that were unknown at the time in terms of, things like public health measures. I said, hey, we're not at that point yet, but we have to start thinking about potential measures such as, quote, social distancing, which at that point in time was something totally unheard of, and looking at what might need to be done in terms of schools and other maybe more restrictive public health measures. So I think you need to take whole context of everything that was said and what we knew at the time. And certainly, as Dr. Tam says, I think we do have humility, as the science evolves, statements made or what we, say and do at a certain point in time based on the state of science at that point of time, certainly that evolves with time.
Just sorry to cut you off, Dr. New, just quickly, I know I have about 10 seconds left. Is the Public Health Agency in Canada and Health Canada planning to conduct a full review and the report of handling of COVID?
As I said, that decision is not up to me, but I do, as I reiterated before, lessons learned are very important with a view to improving our response going forwards.
Thank you, Dr. Tam. Dr. Hanley, please, for 5 minutes.
Thank you, Mr. Chair. First, I'd like to add my congratulations to Dr. Ellis for taking Vice Chair. I'd also like to welcome a new member, Mr. Genereux, to the committee. And we enjoy a productive and collaborative committee here. And I'm sure as a new inductee, you'll learn quickly from your more experienced colleagues around the table. I also want to add a comment for Dr. Tam. Good to see you again. A reflection from my previous role pre-Parliament on your connection to rural and remote Canada, and a vital advocate for rural, remote, and Indigenous Canadians. I think a good example was about a year and a bit ago, a live Facebook update on a weekend with famous Yukon Bhangra dancer Gurdit Pandir and a Q&A for Yukoners. So I think you found many ways to connect with rural Canadians, and I think that may be reassuring for Ms. Goodridge. And on the note, I think the important theme that was just in the last questions answered, I wondered if you could comment, from a lessons learned point of view on how we work with evolving evidence through a new viral threat like this COVID pandemic, but there are many other examples. How we work with evolving evidence and adapt guidance, and perhaps you could reflect on a specific example of the new integrated risk assessment and how that new unit is perhaps helping to provide that ability to keep eyes around the world and adapt risk and guidance quickly.
Mr. Chair, I thank the member for the question. And of course, just to add to my previous answers, we've been looking at lessons learned throughout the pandemic and evolving our response as we're going along. We've had OAG audits. We've been responding to those as well. We've also had external experts to look at our risk assessments and also the Global Public Health Intelligence Network and how we better utilize that. So yes, we took all those lessons and recommendations into account when we established a new Center for Integrated Risk Assessment to bolster our risk assessment capacity that was established in December 2021. And so we are now have increased capacity to integrate different streams of scientific information, not just from data and monitoring systems and surveillance and wastewater, et cetera, but also from the scientific literature that is making things certainly easier for us to produce risk assessment and threat reports. We're now using this center and the methodology to integrate, laboratory genomics, epidemiology, clinical information on new variants of concern. And those updates have been shared with provincial, territorial, and other partners as well. And while the methodology is being stabilized, we should be able to provide, although they're very technical information, more of that in the public domain so that people can see in a more transparent way how integrated risk assessments are done.
Thank you. And if I have time, I'd like to pivot to Dr. Tunis. Thank you for being here as well today. And my question is around ongoing evaluation of vaccine effectiveness, and if you could comment on as I understand, I think for the new bivalent vaccines, we don't have as yet the clinical effectiveness data. I'm sure that's expected in the future, but maybe you could comment on the antibody response data versus expected clinical effectiveness data and how that might add to your recommendations.
Yes, thank you very much for the question, Mr. Chair. So as the members pointed out, the bivalent vaccines, which have been recently authorized and recommended in Canada from both Pfizer and Moderna, have been authorized based on antibody levels and neutralizing antibody titers. So that's not the same as clinical effectiveness, where we see in the real world how many cases of COVID-19, or in particular, how many severe disease cases or hospitalizations and deaths are being prevented. But we have seen in general throughout the pandemic a fairly strong correlation between neutralizing antibodies, so higher levels of antibody can be protective against some of these outcomes. We don't have a correlative protection, so we don't know exactly what line in the sand you can draw to say you will get prevent X number of cases with X level of antibody, but there does seem to be a general trend of correlation that we're observing. So those new vaccines have been authorized and recommended based on higher levels of antibody against Omicron strains, which is a good thing, because as Dr. Tem noted in her some of her opening responses, the direction so far that we're seeing in the variant environment is continuing towards Omicron subvariants. So there's an advantage to having the immune system be primed or boosted with Omicron-containing vaccines. So while we see higher antibody levels in these products, we don't yet have the real-world evidence, and there's been generally a pattern throughout the pandemic of how this evidence comes to bear. So we have research partners in provinces and territories in Canada that conduct vaccine effectiveness studies and monitoring or the surveillance of how the vaccines perform once they're deployed. We know the US and the UK are also strongly based research groups that can issue those kind of data and those estimates. So the general trend that we've seen through the pandemic is once the vaccines are deployed, somewhere between 2 to 6 months after the deployment, we start seeing the real world effectiveness data come in. So we're on that track now that the bivalent vaccines are rolling out in Canada. We know that many millions of doses have been used in the US as well, and also in the United Kingdom. So we do expect to see those vaccine effectiveness estimates start coming in. I will note that the entire vaccine effectiveness monitoring landscape is becoming increasingly complex because we have now multiple different vaccine products that people have had in terms of boosters. They've had different vaccine experiences through their primary series. And also we have different levels of infection from either pre-Omicron variants or Omicron variants as well. So we have a very different mix of a population in terms of who has been infected, who's had X number of boosters. So to actually try and calculate vaccine effectiveness is becoming harder and harder. So it's not probably going to be a simple answer that it's X%, because it has to take into account, will it be X% for people who have been previously infected or X% for people who have had X number of boosters. So it's becoming more and more complex, but we are well established to be able to monitor this and see research estimates coming in the coming months. And I will also note that this is very similar to how we actually conduct influenza vaccine programs, where we, as Dr. Tam noted, have strain substitutions, launch new products in the fall, and then the effectiveness and monitoring comes in months after, and we see how the products perform in the real world. So we're making some early assumptions based on the way that the vaccines have been studied in the trials, and then we're deploying them and following up with the real world effectiveness that can then feed back into policies and guidelines that can be updated, so it becomes a research or a knowledge cycle. Thank you.
Thank you, Dr. Tunis. Next, Mr. Hoback, please, for 5 minutes.
Well, thank you, Chair, and it's nice to be part of this committee for the day. And I guess where I'm going to go to is on the credibility, Chair and Dr. Tam. And one of the concerns I have coming out of the riding of Prince Albert is lack of credibility now in our government institutions all the way around. And I think it shows automatically when you start to look at the people taking booster shots, for example, and the numbers are so substantially lower now than they were, let's say, this spring. And I think part of that comes back to some of the things that have gone on over this last year. One, for example, coming from Saskatchewan, Dr. Shahab would make a recommendation, we'd remove masks, and I'd fly to Ottawa and we'd be fully masked. So Canadians would say, well, how come the science in Saskatchewan says one thing, yet the science in Ottawa says something different? So how do you build credibility back in those scenarios going forward? Because what really scares me is we don't have credibility in the organizations now. And if there was a bad virus that's really bad, where you needed to bring forward the lockdowns and things like we had to do supposedly at the start of COVID, Canadians wouldn't listen to you. They would say, never, we're never doing this again. We don't trust you, we aren't listening to you. And we'd see then the massive deaths that would be the result of that, because we don't have the credibility or the trust of Canadians. So what is your plan to build back that trust?
Thank you, Mr. Chair, and thank you for the question. This is really important, and I think this is why we must come together and work together and earn that trust and keep it up. But I will have to say the outcome for Canada has been relatively good.
The outcome can, excuse me, I'm going to interrupt you here, because the outcome...
No, Mr. Hoback.
No, it's my
time,
time, Chair.
You asked a question that lasted longer than a minute. You interrupted her 15 seconds into her answer. She's entitled to at least as much time to answer the question as you used to pose the question. Go ahead, Dr. Tam.
So between myself and my other chief medical officers, we have regular interactions. They voice the fact that while we're in the same pandemic, everyone is in a different context. We do work with the similar data. So mask use, for example, is very important if the mask is properly constructed and well fitted. Where it differs is how those policies are being applied, whether requirements are being applied and versus recommendations. And we've seen that undergoing evolution over time. But it's the same recommendation in terms of the importance of layering on those protections. It also depends on the epidemiologic activity in the community or the province as well. So that has to be taken into account. And so listening to your local medical officers is very important, but it is difficult in a country as big as and as diverse as Canada that we are not recommending complete blanket approach to everything. And that can sometimes undermine communication and trust, but we do have to recognize that there are differences.
Next level, being in Saskatchewan, we'd look across the U.S. and into Montana, North Dakota, South Dakota, when we were doing our lockdowns, and we're watching what was going on there. And we're saying, okay, their science is saying something totally different than our science. And we see it even today. The Arrive Canada app was taken away finally, and I do want to know what your involvement was in the creation of that app. That's one question. But the other is, we still have differentials in North America on what is allowed, or who and how they're vaccinated or not vaccinated are allowed to cross the border. For example, anybody can come into Canada now, but going into the U.S., if you're not vaccinated, and I hear different stories. If you're at the border and the border officer, a lot of them will ask, some of them won't, but it is different. And that difference creates confusion. So what is the communication between us and the U.S., for example, in this scenario, and what is the recognition of science from other areas as we go into making our decision? And when you make that decision, what is I assume you make the recommendations to the Prime Minister and he makes the decision. How do you square things when the Prime Minister goes to a committee that isn't made up of science to make the final decision over what you've recommended?
So we do maintain close communication with the United States, and no, we're not. I'm certainly not responsible for the Arrive Can application in and of itself, and we can refer you to our colleagues at CBSA. But our VP, who is in charge of borders, is on our panel today if we need to refer to her. But let me just remind you that the United States has 3 times cumulative death per 100,000 population than Canada. So we did do things differently and have been doing things differently. Our outcomes are actually quite different if you just compare the mortality rates, not to mention hospitalizations and other impacts. So yes, you can look across the border, but we actually did do better in the Canadian context by doing things a bit more differently.
And I'm not going to argue with you, Dr. Tam. I actually agree with you on that. But one thing we did notice in the U.S., they could react a lot quicker in their hospital scenarios. They could actually add the intensive care beds. They could add the staff, where here in Canada, I think it was Alberta threw $1 billion at it in, I think, June, and by September, October, they still didn't have one more intensive care bed. So it comes back to, like you said, our healthcare system is so taxed that there's no grace or buffer zone for something like COVID or something that comes along in the future. Plus now it's even worse, because what we've done is we've postponed all these elective surgeries like knees, hips, and shoulders, and we're trying to get them back into the system. And if we were to have another virus or even COVID resurrect into a very deadly virus, we don't have capacity, and nobody seems to want to address that.
Thank you. Mr. Hoback, that's your time.
Mr. Chair, just a quick point of order, possibly point of clarification even. Just from your perspective, again, I'm new on the committee, but you cut off my colleague at the beginning, and I think the reason why was because you said his time had to accurately reflect the witness's time. There's been times where I've been on committee where people have interrupted and they ask for a simple yes or no answer. They've gotten that and they're able to move on. So I'm just curious, like before, I imagine our whips will probably have this discussion, but before it kind of gets to that point, just could clarify your ruling so we have it at least on our side. So if this situation comes up again, we at least know what your perspective is.
In fairness to the people posing the questions and the people answering the questions, the rule of thumb is that the witness be allowed the same amount of time to answer the question as the person who has posed it. So therefore, Mr. Hoback took over a minute to present his question. 15 minutes into her answer, he interrupted her, which is why I intervened. By the same token, if a member asks a short question and, for example, a minister drones on, it's entirely appropriate for the MP to interrupt the witness. If it's a short question, they're allowed to interrupt after a reasonable amount of time. That's been the rule of thumb as I've applied it in terms of chairing this meeting, chairing this committee consistently from the outset, and that's what happened. Mr. Hoback.
In regards to that, I have chaired committees before, and there's times when you need a minute to preface your question, but the answer only requires 15 seconds. And when you see a witness not doing that, then you have the right to interrupt and say, okay, I need to ask. Because you only have 5 minutes, and it is my only time throughout the next 6 weeks to ask these questions. So if I feel the witness either isn't answering the question or has answered it and I want to move on, then I have the right to interrupt. And rule of thumbs are great, but reality is that is not a functioning actual standing order within the committees in that regards. It is my time. So if I decide to interrupt, I expect the chair to respect that and respect my maturity to say the reason I'm interrupting has very important context in what I'm trying to do to get information for this committee. When you've interrupted, you've broken the flow of my questions, and you've taken away my time and my ability to actually get to the bottom of some serious questions for this minister or for this panel because of how you've done it. Now, I appreciate the rule of thumb, but in this case, I think it was totally inappropriate.
You always have the right to challenge the chair. Mr. Johari, please.
Thank you, Mr. Chair, and thank you to the witnesses for coming today. As Dr. Tam, most of my questions is going to go to you. I've heard various versions of pandemic is over or the emergency part of the pandemic is over, but the pandemic continues. Therefore, there's naturally certain uncertainty associated with that level of communication. I know we're recommended to go and take our booster vaccine. I've done my primary as well as the 2 booster. Looking forward going and getting my my bivalent vaccine soon. We talked about the outcome, and that's the best way of being able to measure our success. Had we followed or had we not followed the guidelines that it was set in combination of consultation with our scientists and data, as well as, let's say, the government policies, where would have been? We know today we are at 45,689 individual who has paid the ultimate, sacrifice. Where would we have been if we hadn't followed those? That's really the end outcome. So can you shed a light on that?
Mr. Chair, thank you for the member for the question. And this is a really important point, and one that public health needs to do a better job in that describing what did not happen and what is prevented is not an easy task. The Public Health Agency scientists did provide a publication recently in what we call counterfactual scenarios, where we looked at the impact of vaccination and the collective response of public health measures in Canada. And if we did absolutely nothing, and that was not going to happen. But just imagine if you did not have any vaccines, you did not follow any public health measures, you would have, of course, most of the population being cases, up to 34 million cases, 2 million hospitalizations, that's stress on your hospital systems, and up to 800,000 deaths. Now, Of course, there are many in-between scenarios, whether we looked at the application of public health measures without the vaccine, the application of vaccines without public health measures, and the bottom line is you actually needed both particularly during different times of the pandemic when there wasn't a vaccine and then there is a vaccine. So, and this is why I say that we have to remember the impacts of this pandemic, but relative to other G7 and peer countries, we did relatively well compared to the death rates in the United States, the United Kingdom, and other similar countries. But we have to learn and be humble and learn from other countries that have done better than us as well.
Language, we lost 45,000, over 45,000 Canadian. Had we not followed the rules or the established guidelines, we would have potentially could have lost up to 800,000. So that's, to me, is simple that Canadian understand. Now, you talked about communication, and one of the comments you made is we have to change the way we communicate uncertainty. So again, school is back. We are all going indoor. You know, most of us had at least one booster shot after, and uncertainty is coming. How would we as a group communicate, as a government, as an agency? How should our, let's say, our doctors, our pharmacists, our media, on social media, how should we communicate best during this uncertain time? You're on mute.
You're on mute, Dr. Tam.
Thank you for this timely question. I think we are in absolutely a better spot than we were, of course, even a year ago, despite the arrival of the Omicron virus. And I think what one would say is that we are carefully monitoring the situation. We will indicate what we know as we go along and provide that data to Canadians. But the bottom line is we do have tools, and we have vaccines. We have these bivalent boosters. We know how to layer on our personal protective equipment. We can do something about reducing transmission and severe impacts much better off than we were before. And so while there's uncertainty and we keep monitoring the data and the different variants that we talked about, there's agency. People can do something about this to keep us doing the things that we value the most, like going to school and like going to work.
Thank you, Dr. Tam. Suite to Monsieur Garon pour 2 minutes et demie.
Mr. Garon for 2.5 minutes. Thank you, Mr. Chair. As you know, the House of Commons is sending C31 for study here to the committee, and we will begin the clause-by-clause consideration on Monday at 7 in the evening. I would like to make a motion concerning the work in our committee to the effect that we could reserve the last 25 minutes of today's meeting to begin planning our work on C31. Given that there is probably some hope that we'll be able to hear witnesses on C31 and that we need to work on that before Monday. So that's my motion, that 25 minutes reserved. Thank you, Mr. Gall. I will consult our clerk because this is a procedural matter. If we have unanimous consent, though, we will go ahead as you suggest, but give me a moment, please.
OK, donc nous avons,
Very well, we have a suggestion.
je pense que
I think that it's more than a suggestion, actually. It's certainly a motion being put forward by the member to now undertake a discussion about the upcoming bill.
suggestion that has come forward from Monsieur Garon is that we now move to a discussion around the planning on C31. Now, this is this is something that I would like first to ask whether the committee is comfortable to dismiss the witnesses now and embark on this discussion, and if we can't proceed by consensus, then I think we probably need to have a discussion and a vote on it. So the floor is open. What's the will of the committee, Mr. Vancouverton?
Thank you, Mr. Chair. Merci beaucoup pour le.
Thank you for this good idea.
I don't think it matters. I don't think the motion was in order, but I understand the purpose of it, and I think we could probably move on. I don't think that we need 25 minutes to discuss witnesses for Thursday, but I do think that we need to do it today if we are to have witnesses on Thursday. With respect, I think there's still time with our witnesses, and I don't want to disrespect our witnesses in their presence by suggesting that the last 25 minutes of the meeting is somehow disposable, but we are happy to discuss witnesses for Thursday at the end of this meeting, whether or not that starts now.
Dr. Ellis?
Thank you, Chair. Certainly, from our perspective, we're happy to proceed at the current time. We understand, though, the good nature of the witnesses in front of us and that they will appear regularly anyway. And I think that it's become very clear today that the COVID situation is ongoing and will require our attention in the future. So moving into a discussion of witnesses, I think, at this current time makes good sense. Thank you.
Okay, thank you, Dr. Ellis. Monsieur Garon and then Mr. Blakey.
Well, I would like to thank the witnesses. While I have the floor, Mr. Chair, we're very pleased to be able to have them today, and we're very grateful for their presence. No disrespect intended. When we call witnesses to testify, at that point, when we called these witnesses, we didn't know that the government would be insisting on moving ahead on C31 quickly. Unfortunately, that's the situation now. It seems that we must move quickly on C31, even though I disagree with that approach. I will respect it. So we might start the clause-by-clause consideration Monday evening. So due to the time limitation imposed on C31 discussion, we have little time left to plan our approach, and we also have less resources for the meetings and must plan ahead to ensure we do receive the resources we need. So it would be difficult to wait until next Thursday to plan. We already have a pretty much mission impossible before us, and to my point of view, democracy is suffering for it. Second, we need to be able to plan for the additional resources we need, and then we'll be able to work out a witness list. And once we've finished with the motion, that will take about 15-20 minutes. It's already going to be difficult to get through it. That's why I'd like to stop talking now. That said, I certainly sincerely thank our witnesses from PHAC and Health Canada.
Mr. Chair, of course, I'm at a bit of a disadvantage here being a sub on the committee. Sounds like an important conversation for planning out committee business that I will not be a part of. So, I mean, my preference would be that the committee find time to do this when there's been a little bit more opportunity for some discussion among the parties in advance of decision making. I think that would be very useful, which is why I'm not keen to proceed on to a discussion of committee business where I'll be making decisions for others without what I take to be the appropriate context for the committee. That said, if this is about responding to something that's happening in the House and there's some need for witnesses, I'll speak from my experience, not at this committee, but at others. That can often be resolved by the submission of witness lists, and if in the chair's discretion, there's going to be an additional meeting held tomorrow, or if the business for the meeting on Thursday is going to change, then I think if it's about ensuring that we have appropriate witnesses for the subject matter at hand, that's something that needn't be done right now at this table, but can be done with discussion among the parties shortly after this meeting. Parties could submit their witness list by the end of the day, for instance. So I'm not sure that we need to lose what time we may yet have with our witnesses in order to have a well-functioning and productive conversation about how to have witnesses in time for Thursday, for example.
Ms. Goodridge and then Mr. Vancouverton.
Thank you, Mr. Chair and Mr. Blakey. The original conversations that were happening were to have these conversations around witnesses for Thursday, which would effectively leave no time to hear from witnesses before we embarked into clause by clause. And so I think this is a very intelligent compromise that was found by our Bluck colleague to allow for some space for witnesses to be able to present it. We are not saying that we are going to pick which witnesses in this meeting. This is about setting the agenda through committee business so that we can proceed to have some witnesses to appear on this bill prior to doing the clause by clause that is forced by government motion to happen starting on Monday. So this is simply to give a little bit of space, and I would think that the New Democratic Party, a party that has always supported the democratic process, would be in favor of hearing witnesses on an important bill such as this.
Mr. Vancouverton.
Merci, Monsieur.
Thank you, Mr. Chair. If we would like to discuss the choice of future witnesses now.
Use them, and we should, if we are to discuss witnesses, go into camera for that discussion instead of having that chat in public.
All right, there are no further speakers. I'm not sure that we do have a consensus. Mr. Blakey.
Yeah, I guess my question is whether the purpose of the discussion that's envisioned by the motion would be for setting additional meeting dates, or whether it would be to talk about which witnesses would come to provide testimony. That's still unclear to me. So if I just had a better sense of what the decision points are that people want to arrive at, then I'd have a better sense of whether I can meaningfully contribute to those decisions in this moment, or whether we would need some time to be able to consult with our critic, who's obviously not at the table today.
Mr. Gatto?
Well, I was making the suggestion to serve the process, the parliamentary process at our committee. There's nothing partisan here. That's not what I'm up to. We must make a choice. Either we really get at it quickly as of today and begin planning our meetings and the resources needed to have them, or we plan nothing and we simply go to clause by clause consideration without having made any decisions about the process we're undertaking. Today we've got a little elbow room, a little wiggle room. Even now, I haven't any specific witnesses whom I would propose. I've got nothing in mind, actually, but I'm saying that if we don't move on this now, we'll never have a chance to do so. Given that we have an accelerated process imposed on us now, that we have a time limitation, we have to accelerate things here as well.
Okay, seeing no further interventions, I guess we're ready for a vote. Is it the will of the committee to dismiss the witnesses and embark on a discussion on planning for C31? All those in favor of proceeding this fashion, please indicate by raising your right hand. I see. Okay, it appears that it is in fact unanimous. To our witnesses, first of all, thank you so much for your patience. Sometimes democracy is a bit messy. We always appreciate your expertise and how willing you are to come before the committee and answer some challenging questions. Thank you so much for your service to us and to Canadians. I wish you all a great day. Thank you. Colleagues, Let me set the stage as follows, just to summarize some of the discussions that have been had and where we are in respect of C31. The first thing I want to point out is that we are presently in public. If there is a wish to go in camera, that's going to take some time, probably all the time that we have allotted. So, and normally if we're going to get into discussion of witnesses, we would do that in camera. But let's just let me say this. The motion, as I understand it, that is being debated, if it passes without amendment, will mean that we will be obliged to proceed with clause by clause on Bill C-31 on Monday. We are not allowed to commence that clause by clause before 7 p.m., but at midnight, any debate on clause by clause amendments will be finished, and as of midnight, the only thing left will be voting. So what the motion does not preclude us from doing is from starting at any time to hear from any witnesses we wish. So there's the informal discussions that have been had were headed towards this Thursday's regular meeting slot being dedicated to a planning of whether we were going to call witnesses other than officials and who they might be, and that meeting would be in camera. And if at the end of that meeting we had time, we would continue on with the consideration of the Health Human Resources report. In any event, it was my intention to invite to Thursday's meeting a legislative clerk, because for many this will be the first time actually going through the clause-by-clause process, and having a resource here from the House to either to brief us or to answer questions with respect to that process, I thought would have some value. So if I know we have limited time, what I would like to pose to you is this. Given that we're in public, I don't think it would be appropriate to get into specific witnesses. What I think would be useful would be, how do we want to hear from witnesses other than officials after 7 p.m.? If so, how much time should we allocate to that? We take precedence over all other committees with respect to House resources to get this through. So we will allot as much time as the committee wants, and then perhaps call for submission of witness lists so that we can boil down to who. So I would prefer if this discussion is about how much time and not about the specific identity of witnesses, given that we're in public. The floor is open. Mr. Van Couverden.
Just briefly, can I ask the clerk that considering that everybody's in the room, would it take more than a minute to go into camera?
We're looking at that right now. The question really is party officials that aren't in the room. The committee rules do allow party officials to join Zoom. So if we were to proceed in that fashion, then that would exclude those officials.
So, Mr. Van Couverden, just after consulting with the clerk, we can, by unanimous consent, waive the requirement of allowing House officials, members from the Government House Leader's Office, et cetera, to participate virtually. We can do that, we'd have to do that by unanimous consent.
I feel like that's above my pay grade a little bit, but I think what I could ask is just, do we want to discuss specific witnesses or whether or not there's witnesses? Because we can do this out of camera, I think, if we're just discussing the broader concept of whether or not we're having witnesses.
Monsieur Garand and then Dr. Ellis.
Well, here's the suggestion that I can make. First, let's draw up a timetable so that we can have extra meetings to receive witnesses in. Let's agree on that. Then let's agree on the possibility of submitting to the clerk by Friday at 5 in the afternoon, for example, a list of potential witnesses so that we could go ahead and plan which witnesses we will be hearing. I'm certainly aware that some of us are sensitive to the matter of having substitutes in committees, perhaps 2 or even 3 meetings then, of 2 hours each. That's a lot, but this would give us time to hear witnesses, a long day on Monday, to ensure that John is back and so on, and so Dan be back and so on, and so forth, to respect everyone's availability. Obviously, well, it'll just be a long day Monday, but that's the nature of our work.
Thank you, Chair. I think it important of a couple of things, just for clarification, if I could. Obviously, we have House resources as a priority. Does that mean that when does that actual priority start? Will it start on Thursday, for instance, and continue through the weekend? If you'd like to answer, I just had a couple other things, but please.
My understanding is that it will start the minute the motion is adopted.
Okay, and of course, after that, I do think it important that we have an in-camera discussion with respect to specific witnesses who we're going to want to appear before the committee. So, you know, I certainly think that we have limited time today. I would suggest that we're going to need an in-camera meeting on Thursday and submission of witnesses by Friday at 5, which also could possibly mean meetings over the weekend on an urgent basis.
Mr. Blakey?
Just remercier Monsieur Garon de...
I would just like to thank Mr. Garon for his suggestion. I think this is a good way to go ahead. And I would be ready to support such a motion.
We have 2 suggestions, one from Monsieur Garon, that we, in addition to meeting at 7 p.m. on Wednesday, that we have Monday, that we have 2 2-hour sessions to hear from witnesses. And we have a suggestion from Dr. Ellis that Thursday's meeting be in camera and dedicated to the identification of those witnesses. I don't think those 2 suggestions are inconsistent. Is that a fair summary of where we are, and are there any further interventions? Ms. Goodrich.
Well, considering that the minute the motion is passed, we gain access to having priority of resourcing, I would suggest that we not hold ourselves to waiting till Thursday and perhaps have a meeting on Wednesday to have these discussions, so that we're not behind the 8 ball and having to work through the entire weekend trying to catch up.
Dr. Pawlowski.
I thought, I don't know when else to say this, but there is the question of working on the weekend that's come up. I would suggest that several of us have family. I'm not sure what the urgency is in getting this done all of a sudden, requiring us to work on the weekend and forego our time with their families. So,
Dr. Ellis and Mr. Garon.
Thank you again to have the floor, Chair. But in response to Dr. Pawlowski, I think the difficulty here is it's your own party who's causing the difficulty. You are pressing this issue to say how urgent it is. This is not the doing of this side of the floor. So if we have to work through the weekend, then so be it. I mean, I don't want to work through the weekend any more than you do. But that being said, maybe you need to have a discussion with your own party to say, why are you pushing this legislation so hard and so quickly? When I think it needs, as does Mr. Garon, I don't want to suppose that I speak for him, but this requires due process. And I think that in order for us to be any part of spending at least, let's be honest, $10 billion more, that boulder thrown into a teacup, not the small stone thrown into a lake, but a boulder thrown into a teacup of money, I think that it behooves us to be able to be here to support the Canadian people and have appropriate lists of witnesses. Does that mean that it's going to take the weekend? It may very well do that. And if it's uncomfortable, unfortunately, for several government ministers, then so be it, and requires their plans to change. I do think as I said, it behooves us as parliamentarians to look at a $10 billion piece of legislation in a very careful and systematic way and to also be able to bring witnesses that will be able to contribute to that discussion in a very forthright and honest way, and to be able to have a fulsome discussion on that. It is going to take some time, and it's unfortunate, as you said, Dr. Pawlowski, that your government wants to push this legislation through, but I think from our side of the aisle, we'd like to make sure that we have a fulsome discussion on that. So, but thank you very much for bringing that forward. I really appreciate it, as always.
Mr. Garand and Mr. Blakey.
Je réitérerai ma...
Well, once again, I suggest that as of now, we decide that on Monday we will have an 11 to 1 in the afternoon meeting, and then another one during the afternoon, as well as the one beginning at 5 in the afternoon, or 7 in the evening, rather, and that we agree that we start planning for these and offer the clerk our list of witnesses by Friday. But right away, we could decide on these extra sessions for Monday so that we could then work on our witness list and continue this conversation on Thursday, when we might decide if we wish an extra meeting on Friday or even over the weekend. But the part we can agree on, the Monday, we could certainly agree on now, and consensus can be reached on that.
Very well, I'd be happy to move to making a decision on his proposal.
All right. So, Monsieur Garand has proposed that we, on Thursday, in camera, discuss witnesses, that we commit now to holding two-hour meetings on Monday in advance of the 7 p.m. meeting, where we're able to go to clause by clause, and that any additional time that may be required is something that we will leave to decide at our Thursday meeting. Ms. Goodridge has suggested that that Thursday meeting where we go in camera to discuss witnesses take place tomorrow. So those are the two proposals in front of you. Again, I don't think that they're necessarily entirely inconsistent. So if there are any interventions, great. If not, I'm going to put both of them to you in I guess in the form of a question. I see none. So is it the will of the committee to schedule an in-camera meeting tomorrow to discuss witnesses? All those in favor of meeting tomorrow, an additional meeting to discuss witnesses, please raise your right hand. Opposed? Okay, so we will not be meeting tomorrow. Then we will be meeting on Thursday at our regular time in camera to discuss witnesses, and also to discuss what additional time needs to be allocated over and above the 4 hours on Monday. So I just said that as if it's a done deal. So where we are then, the proposal before you now is that we will have an in-camera meeting on Thursday to discuss witnesses. We will set aside at least 4 hours on Monday for that purpose, and such additional time as may be decided on Thursday. Is it the will of the committee to proceed in that fashion? I see heads nodding all around the table. Okay, so we have consensus that we will meet on Thursday in camera to discuss witnesses, and for at least 4 hours on Monday, in addition to any time that we may any additional time that we may decide this Thursday. Is it the will of the committee now to adjourn? We are adjourned. Thank you.